a pleasure to welcome you to today's program. Before we get started, I'd like to orient you to the functionality of the webinar system that we're using today, which is GoToWebinar. Today's program will be recorded and made available on our website following today's presentation. During the presentation, as a courtesy to the speaker, all phone lines are automatically muted. If you do have a question, however, for the speaker, please feel free to send all questions via the moderator inside the chat box, which is located on the right side of your screen. Our guest speaker will answer as many questions as time permits. Now it's my pleasure to introduce you to today's speaker, Dr. Marietta Iacucci, the Reader and Senior Associate Professor of Gastroenterology at the Institute of Translational Medicine at the University of Birmingham, also the academic lead in gastroenterology and an honorary consultant gastroenterologist. Dr. Iacucci also serves as the Adjunct Clinical Associate Professor of Medicine at the University of Calgary. It is my distinct pleasure to welcome Dr. Iacucci to the virtual podium. Dr. Iacucci, go ahead with your presentation.
Hello everyone, and I'm so pleased to present today in this webinar the new era of optical enhancement in inflammatory bowel disease in endoscopy. So these are my disclosure. And what are the hot topics in IBD? Is to assess inflammation, to treat to target, to achieve mucosa healing, sustain healing, and surveillance colonoscopy. How should surveillance be performed, and how dysplasia should be managed in patients with inflammatory bowel disease? Everybody knows the current endoscopic scores used in the daily endoscopy practice. The Mayo endoscopic score and the recently validated the U-State score. The normal, the Mayo endoscopic scores use basically the grade of the disease, and 0 is normal or active disease, 1 is mild disease, Mayo score 2 moderate, and 3 severe disease. And they look at erythema, decrease of vascular pattern, erosion, ulceration, friability, and spontaneous bleeding. The recent U-State score is more precise in introducing detail in the vascular pattern, in the bleeding, in the erosion, and ulcers. However, these endoscopic scoring systems in ulcerative colitis, they have some limitations. Limitation, for example, of Mayo score, is partially validated. There is no endoscopic definition of mucosa healing. There is a low inter-observer agreement between the raters, and there is overlap between grade 1 and 2. The U-State is validated, but however, again, we don't have an endoscopic definition of mucosa healing, which now represent the gold therapeutic standard to achieve in terms to change the outcome and natural history of ulcerative colitis. There is no threshold between mild, moderate, and severe ulcerative colitis, and there is no definition between superficial and deep ulcer. But in the clinical trial, in the daily practice in the clinical trial, mucosa healing, so Mayo score 0 and 1, both these are considered mucosa healing. However, recently, this recent study has showed that Mayo endoscopic patients with ulcerative colitis, a Mayo endoscopic score of 1, they have higher risk to flare up, 36.6%, compared with Mayo score of 0, which is 9.4. So it's becoming important to improve and characterize the endoscopic healing in our patients, because we can prevent flare-up and we can optimize our treatment. If you look at this Mayo score, with the white light standard endoscopy, we can barely differentiate between mild inactivity of the disease or mucosal healing. But the new brightness generation of the endoscope with high definition and with high resolution, they can define in details the mucosal, the scar has endoscopic healing, and the mild inflammation. The new generation, new modalities of endoscopes have been developed, and these new endoscopes, they better characterize and enhance the image. We have the NBI, the Fusion, and the new latest generation of optical enhancement scan, which is the unique combination in one scope. We have post-processing digital chromoendoscopy, which is scan 1 and 2, and has the capacity to detect and characterize pattern mucosal. And with optical enhancement, like NBI, we have more basal characterization. We can almost see in vivo diagnosis. But how can we see better with this new technology? We can characterize and enhance details, mucosal and vascular pattern, and so starting to talk and define mucosal endoscopic feature healing. We can assess grade of inflammation. We can predict response to treatment, and we can in the future treat to target and sustain mucosal healing. And important, with the new technology, we can perform surveillance, and we will be able, as I will show you later, to characterize our lesion. So we have developed, recently we have developed a new virtual endoscopic score in ulcerative colitis, and we define the concept of endoscopic mucosal healing. And we showed that this OE-iscan virtual chromoendoscopy score defined by mucosal and vascular pattern is great correlated with Mayo score and with HARPA's histological grading. We wanted also to develop a new histological score, namely ECAP, which was more comprehensive of chronic and acute changes. And very interesting, we have showed that patients with complete mucosal healing defined by Mayo subscore 0 still demonstrated abnormalities by a scan and histological ECAP system. So we graded the normal mucosal pattern in normal, mosaic pattern, tubular gyrus, nodular rosette, and our vascular pattern in normal, spiral isolated vessels, crowded tortuous vessels, and irregular vessels. And I give you now some examples. So you can see here the high definition. This is severe ulcerative colitis, but with a virtual chromoendoscopy, so with a digital virtual chromoendoscopy, you can define these tubular gyrus, you can define these dilated vessels in the rosette mucosal pattern. And with the mucosal healing pattern, and also with interesting, you can use the water immersion also technique, which enhance more your mucosal architecture and your crypts. You can see this very clear, and with a virtual in combination with a virtual chromoendoscopy, you can see this mosaic pattern. In the healing, the vascular healing, we find that these patients, so you can really see this cut of this normal vascular with this isolated spiral distorted vessels. And also with the virtual chromoendoscopy, we define the scarce tissue. The same recently, the Japanese, They also, with the narrow bending imaging, they just showed the importance to assess the vascular pattern in patients with ulcerative colitis. And so we cannot talk anymore about loss of vascular pattern of variability. And they define 3 categories of vascular architecture: the normal honeycomb pattern, the shaped like brains, and then the type C, which they showed that patients with ulcerative colitis with blood vessel like C, they had more flare-up. So this is really important because the great assessment of your vascular pattern prevent and predict outcome, flare-up, and complication, and help you and hide endoscopists in the IBDology to optimize the treatment. But the future at the horizon is the new generation of the scopes. Some they are already in use, some they are upcoming. And the new optical enhancement OE-iscan is the new combination of digital post-processing image and optical enhancement with biopsies with magnification. So the physician in the daily practice, they can look at with high definition, which is detection. Then in real time, they can just simply push the button on any piece of the scope, and they can characterize with OE-iscan 2 and virtual chromoendoscopy. They can see the vessels, the ulcers, the pattern characterization. And with optical enhancement, with magnification, they can see the vessels, the crypts characterization. So we have, at DDW this year, we have presented our first experience and behind the white light endoscopy using the new optical enhancement. And we have showed that the optical enhancement can see in details abnormalities. And we have defined for the first time the endoscopic healing in ulcerative colitis. We have enrolled 50 patients, and we have modified and improved the previous virtual OE-iscan chromoendoscopy score. And we have defined the mucosal pattern in mucosa healing, roundish, dilated, mild and mosaic, mild inflammation, and roundish crypts with microerosion, moderate inflammation with mosaic elongated erosion, severe inflammation with a crypts necrosis with hyperplasia or crypts and ulcers. And the vascular pattern in roundish surrounded the crypts is a normal vascular healing. Vessels drop out or isolated spiral vessels. Mild inflammation is roundish crowded tortuous vessels. Moderate inflammation with dilated vessels with luminal bleeding and vessel in the intraepithelial bleeding, and severe inflammation with the vessel destruction and spontaneous luminal bleeding. We have compared our score with the ECAP score, which is our histological score, more comprehensive of chronic and acute changes. But we have used also as a comparison the new validated histological robust histological index, which has a great reliability in assess acute changes. We have showed great correlation, good correlation of endoscopic Mayo score and optical enhancement virtual chromoendoscopy score. We have showed also good correlation of the optical enhancement with the histological score and especially with ECAP, because ECAP can see in details chronic changes. And we have also demonstrated a good accuracy of the optical enhancement to detect abnormalities especially with ECAP. And now I show you some examples. So I show you what you can see with this new optical enhancement. So you can see the opening of the crypts. You can see dilated vessels around it. You can see the intraluminal bleeding. You can see the small erosion, the crypt necrosis, and the ulcers. But the most relevant and important, you can see, here seems is normal, this mucosa, but when you then switch in optical enhancement and in magnification, you can clearly see that there is alternating areas of inflammation, patch inflammation, and spiral isolated vessel healing, vascular healing. So this technology, they can help you in the future to target these biopsies, this area, and assess mild inflammation and optimize your treatment, prolong your treatment in terms and prevent flare-up. And this is the healing. So you can see the healing with magnification, you can see the scar, you can see the spiral isolated vessels. And now I want to give you in real time with this video clip the real life. So you can see here the ulcers, this is a magni view, so magnification, the dilated vessels, the ulceration, and with the optical enhancement, you can see the crypt necrosis, you can see the vessels and the luminal bleeding. This is the scenario of severe ulcerative colitis, but look at here the mild activity. So almost normal to white light, the optical enhancement and the magni view show you this patchy area of inflammation, and you can define the erythema and the spiral vessels, so you can target your biopsies. And this is a mucosa healing. Spiral, distorted, optical enhancement give you more details, scar, and so this is healing, completely mucosal healing. But moving in another hot topic in IBD, we need to talk about surveillance. Surveillance is still debate, how surveillance should be performed and how surveillance should be, and dysplasia should be managed. And the standard of care is chromoendoscopy, is considered a chromoendoscopy. We are moving from random biopsies to target biopsies and from colectomy to en bloc resection. Where we are going? So the ECHO guidelines in 2013, they recommended the chromoendoscopy with target biopsies is the standard of, should be considered the standard of care to increase the detection rate of intraepithelial neoplasia in patients with IBD. And recently, the CINIC meta-analysis of chromoendoscopy confirmed that chromoendoscopy has to be adopted as a standard of care for improved detection rate of dysplasia in patients with long-standing IBD. However, there are 8 studies, and there are a variety of patients between 160 to 48. But interesting, CINIC guidelines introduce the new terminology, common terminology to, for the endoscopies. We introduce polypoid, so the Paris classifications, polypoid, no polypoid, and then most important, they introduce the border, distinct border and distinct border, because there is a new concept which is the resectability of the lesion and organ sparing. Adding value to the chromoendoscopy, there is also this parallel group randomized trial which showed that the high-definition chromoendoscopy was superior to detect more dysplastic lesion in patients with ulcerative colitis compared with high-definition white light endoscopy. And again, Marion confirmed. In this prospective study of 68 patients, the chromoendoscopy was superior to random biopsies for detecting dysplasia. However, in this large real-life cohort study, this cannot show the dichromoendoscopy was superior to white light endoscopy to detect lesion in IBD. In our large Calgary cohort study of 454 patients showed that the target biopsies identify a larger proportion of lesion when patients undergoing the high-definition dichromoendoscopy, virtual electronic chromoendoscopy. But we couldn't show that dichromoendoscopy was superior if high-definition endoscopy were used. And in this our completed now randomized comparison study presented at DDW this year, we enrolled in the random 270 patients. And we wanted to determine the optimal technique to detect dysplastic lesion in IBD. We enrolled 90 patients in high definition, 90 patients in dichromoendoscopy group, and 90 patients in virtual chromoendoscopy group. And we show a trend favoring of high definition in detect dysplastic lesion. However, there was no statistical significance between the three groups. And also when we look at the sensitivity, specificity, accuracy, positive predict value, negative predict value of the three techniques, they were similar. So we conclude that our results indicate the dichromoendoscopy is not sensitive or the high definition or virtual chromoendoscopy were not inferior to detect dysplasia, colonic dysplasia compared with chromoendoscopy. However, further large randomized trials are needed to establish really the role of dichromoendoscopy in the daily standard practice. So what I do and what I suggest, I like the blue heart, and I use my blue heart for detection. So when I need to perform a surveillance in IBD, I use my blue heart and my dichromoendoscopy. And what do I need? I normally use my foot pump jet. It's also standard for CINIC guidelines, and I put the vials of indicocarmine in 250 milliliters of saline. And then with movement of clockwise or anti-clockwise of my scope, I just painting uniformly in the column. But how do you optimize your surveillance? First of all, you need good optimal bowel preparation. Then it's important you perform your surveillance with minimal or mucosal or no inflammation. And the goal is the withdrawal time. The withdrawal time and the careful inspection is really important to increase the detection rate of dysplasia in IBD. I consider 45 minutes in time of my procedure, and I complete my colonoscopy to the cecum, and I try to clean as I can and suction all the extra debris and liquid during my insertion. And then in a withdrawal time, I start with my foot pump jet, and I just painting with the indicocarmine. And in the circumferential, and I analyze and I inspect every 20-30 centimeters of my colonic mucosa. And if I find a lesion, upon the lesion, I use the normal concentration of indigo carmine or methylene blue. I assess my margins and I assess my lesion, and if the margins are definite and the characteristic in the lesion, I remove endoscopically. This is an example how I do my chromoendoscopy. So you can see here with the pump jet, with the clockwise circumferential movement, I try to painting uniformly my mucosa, and then I go in again, suction, and analyze 20 to 30 centimeters of my segment. But chromoendoscopy is better. Why I'm not using yet in my inflammatory bowel disease patients during surveillance? There are so many unanswered questions. First of all, we need more prospective multicenter studies. We cannot rely only in the previous white light standard endoscopic study. We need to put into account the new technology, and we need to use the novel endoscopic technology, understanding the value in terms of detection and characterization of lesion. We need to stratify of cancer risk and understanding the stratification, interval of surveillance, natural history of dysplasia. We need also to control our inflammation. We need to define a score and validate endoscopic healing. We need to introduce also concepts like endoscopic response, endoscopic partial response, endoscopic refractory. We need also understanding the cost and benefit of the chromoendoscopy. We need training, education program for chromoendoscopy technique and for characterization of the lesion, introducing also the optical biopsies. And it's also important understanding in the future if the surveillance has to be performed by everyone, or we need to include in the IBD unit a IBD endoscopist. So the concept is also this, Cynic introduced the term of endoscopic resectable. So it's important to assess. It's not just important to detect the lesion, it's also important to assess and characterize the lesion in terms to resect, in terms to save the colon. So it's important the color, it's important surface pattern, it's important vascular pattern, it's important only the bias classification, it's important. So we need to understand all these features. So in terms of characterization, so how should the colonic lesion in IBD be characterized? It's so just important to detect, or we need some classification, or we need international classification. They can assess vascular, mucosal pattern and endoscopic features that can tell us, predict dysplasia, and tell us how to manage this lesion. Do we need the colonic characterization can help to better manage this endoscopic lesion? This, do we need to better define the area surrounding because to avoid multiple time-consuming biopsies, maybe not target random? And then there is another chapter which is really important, and is how do I manage the pseudopolyp, and how do I need to stratify these patients with carpet scatter or mass pseudopolyps? So when I see this lesion, so I'm doing it with my hot glue, I see the lesion and say, wow, this is the lesion. And then probably now I need to characterize. It will be great to change, I change my hat and I use my colorful hat, because now the new generation of the scopes are widely used in the most of an endoscopic unit. And they are just by simple pressing a button, and you can have so the blue hat detection, the colorful hat characterization. and I can characterize my color, my size, my Paris calcification, my vascular invasiveness. The CUDO. CUDO is a debate. It's still debate. We don't know yet if it can be embraced also. We can be used the CUDO classification for the colonic lesion in IBD, because we know most of our patients, they have abnormal mucosal pattern due to the chronic inflammation. So it's very difficult to differentiate the CUDO-PIT pattern. So I give you now an example of the both hat. So you have the same lesion, you are doing dichromy endoscopy, you detect your lesion, you see this is a no polypoid lesion, it's a Paris 2A, and then you will use also the other colorful hat. After your detection, you will wash, you will look at with chromoendoscopy, and you will use all your toys, because all your toys give you the possibility to assess your vascular pattern, your margins, your mucosal pattern, and decide for best optimum strategy, endoscopic management versus colectomy. And now I'll give you some examples. So you can see here, barely you can see in white light, the high definition, you define much better your margins, deletion. With a virtual and dichromy endoscopy, you can gain more endoscopic features. And here again is a real-time video clips. This lesion, this was a patient with ulcerative colitis, a primary sclerosis cholangitis. You see with all the technology, with virtual and dichromy endoscopy, you can assess margins, you can assess pit pattern, you can assess also this is a dichromy endoscopy, so manage your treatment. So which way? This way, which is a chromoendoscopy, or that way, which is virtual chromoendoscopy? I would say both hot. I will say both way, they are together to better detect and characterize your lesion in IBD. And now I give you an example of how many phases you can have, how many phases the colonic lesion in IBD they can have. You can have this flat, this no polypoid lesion, and you see here in white light high definition, and then you see in dichromy endoscopy and virtual chromoendoscopy. The virtual chromoendoscopy give you, the dichromy endoscopy give you more definition of margins, but virtual chromoendoscopy give you more definition of vascular, and so you can predict invasiveness. And then here again, the same lesion you saw in the video clips. So high definition, the virtual chromoendoscopy look at you have more vascular pattern, and dichromy endoscopy margins and mucosal pattern. In this lesion, in white light, you barely couldn't see this lesion. And then with high definition virtual chromoendoscopy, you see that beside these scars, there are abnormalities. This is dysplastic changes. And then here you see this villous appearance, which this is a dysplasia, was not a polyp. And also if you look at here, this adenoma, seems is an adenoma, but look at it with the virtual chromoendoscopy, you can really see this is no an adenoma, and there is still dysplastic changes here. This is a courtesy of Professor Oga from Japan, and this is a patient with ulcerative colitis. You see here this lesion, dichromy endoscopy, which in the Japan people, in the daily practice, they use the combination of technology. So they use selective chromoendoscopy, virtual and dye. So with NBI, you see they define the margins of deletion, the pit pattern. They use CAS violet for the predict invasiveness, and then the endoscopic mucosal dissection, and this was a tubular adenoma. So patients, they saved the colon of the patients. And this was a lesion, another lesion in IBD, in ulcerative colitis patients. So you see in high definition, you can define just this lesion, but then with dichromoendoscopy, you can see the lesion. It's semi-circumferential. With the MBI, they define the vascular pattern, the margins of the lesion, planning, strategy for endoscopic resection, and with the Kreisel violet, the invasiveness, and this was the lesion, endoscopic submucosal dissection was successfully removed and was a tubulovillous adenoma. But moving to the future, where we're going. The new generation of scopes, now with combination of digital, of optical, with magnification, without magnification, with close focus and zoom, they give us more details. So with now, you can see here, you can define the cut margins. So you can define your open crypts, and you can really detect, characterize, and resect your lesion. And I give you a video clips, real life time, where you can see here, this is the optical enhancement, the new OE-iscan optical enhancement. So you can see here with OE and magnification, you can define this flat lesion with margins, pattern, vascular. Interesting, you can see the mucosa surrounding, so and the opening of crypts. So this is another lesion. So just to conclude, what is the message to take home? First, the future approach to assess inflammation, we need a new validate score, a new virtual probability score with using this novel optical biopsies, virtual chromoendoscopy technology, then characterize mucosal vascular pattern details and can define the concept, endoscopic concept of mucosal healing, a patch inflammation, and it can help us to target biopsies, to optimize our treatment, to prevent flare-up and complication. With so the novel advanced electronic endoscopic technology, the physician can assess inflammation, can personalize treatment in the future, because the endoscopy is the principal endpoint of outcome, a therapeutic and goal. We can talk about endoscopic healing, endoscopic response, endoscopic refractory, endoscopic partial response. And regarding the surveillance, I think we should use both hats. We should use chromoendoscopy for detection, and we need to change our hat with virtual chromoendoscopy and using the new generation just by simple press the button on the end piece of the scope to characterize the lesion and predict invasiveness, histology, and decide to save our colon for our patients. And maybe considered we need to potentiate education training and training module for not just performing surveillance chromoendoscopy, but to characterize with optical biopsies the lesion and prevent organ sparing. And I want to thank you, and I'm open to the audience for further questions.
Perfect. Thank you very much, Marietta, for that wonderful presentation. At this time, we'll now open the program up for question and answer from the audience. As a reminder, to ask a question, simply ask your question through the chat box, which is located on the right side of your computer screen. All chats will be answered in the order in which they're received and will be answered as the speaker has time to answer them. We'll give you just a few moments to ask your questions in the chat box. So Marietta, the first question that's come in is specifically about the virtual endoscopy. Are there specific training resources that you could recommend for newer endoscopists to enhance their skills to be able to use them for diagnosis of IBD?
Yes, we are working to create a training module, and I think the American Society of Gastrointestinal Endoscopy, and here also now in UK, we're trying to create a standard training module based on the workshop, small masterclass live endoscopy, and also computer software to improve interactive, also computer software, just to improve and just help these people in terms of education program and in characterization of lesion, which I think now is becoming the most important goal, because I think it's not difficult to do a chromoendoscopy technique. The problem is that when you find now this lesion, you need to characterize, because you need to decide in real time if you can remove or not. So we need, there is a need now of improve education and training module to achieve this goal.
Perfect, thank you very much. And the second question that came in is, you had mentioned that local resection, might be sparing to prevent a total colectomy. Are there certain techniques or skills that an endoscopist would need to have in order to really be able to use this advanced treatment to enhance the patient outcome?
But techniques is the endoscopic mucosal resection and or endoscopic submucosal dissection. The Japanese, they will do the endoscopic submucosal dissection fantastically. And definitely, so I think we need the advanced expertise in endoscopy. So, but if you can really characterize your lesion and is just isolated, the margins are defined, there is not invasiveness or prediction, you can use EMR or EST to resect the lesion.
Perfect. Thank you very much.
We are moving also in another direction. The future, it's the surgeon is also considering now the segmental resection, because with the new technology, we feel, and expertise and experience, we feel quite confident to perform surveillance in the future in these patients, also with segmental resection.
Perfect. And it looks like the last question that came in is specifically to the ongoing maintenance and surveillance of IBD patients after endoscopy. Are there certain pharmacologic drug treatments that you have seen in your practice are most effective at maintaining those patients in a very comfortable state post-procedure?
So you're talking about medical treatment in terms of maintain control inflammation?
That is correct, yeah. That's correct. Yeah. The question was specifically about that.
I think controlling inflammation is a great point. This is the reason why we're talking about mucosal healing, and definitely it's a very debate if chronic inflammation or sudden inflammation increase the risk of cancer. Seems yes. And this probably is also the reason why the primary sclerosing cholangitis patients, from my experience and looking also with another technology with confocal lesion microscopy, they have still chronic inflammation without symptoms. So I think my experience is if we control inflammation, we can reduce the risk of cancer in these patients. And regarding drugs, this is different. You know, the depend. You're talking about Crohn's disease, you're talking about ulcerative colitis, depend of extension, depend of activity. You know, I like to, in patients also with remission, I like to maintain the dose of 5-SA in these patients of mine. And when I have mild or moderate activity, chronic activity of the disease, and the patient doesn't respond to the normal treatment, I like to control with biological therapy.
Perfect. And I think the last follow-up question that just came in is specifically from a primary care physician, and he really wants to understand, what do you see the role of primary care, so not our specialty gastroenterologists, but really our primary care physicians in also co-managing IBD disease after you know, these patients their inflammation has calmed down essentially. So are there specific strategies that you see for collaboration with non-gastroenterologists that we should be considering?
I think it's really important. I always thought in my life, in my practice, then we need to communicate and collaborate and being a teamwork. So, and I think I give you an example in terms if we are talking about inflammation, definitely the primary care can just start the first step of care. And then if there is some complication or patient doesn't respond, we're talking about inflammation. So it would be great if there is communication between the IBD specialist with more experience and the you know, community gastroenterology. In terms of surveillance, I strongly recommend it. If you do very great, I'm sure everyone can do great chromoendoscopy after training, but if you detect the lesion, maybe it would be great if you just can send the patients for another reassessment to the tertiary referral with more experience of optical biopsies, characterization of lesion, and advanced therapeutic endoscopy.
Perfect. Thank you very much for both the timely presentation as well as the great question and answer. So I'd like to thank you for your insightful presentation. I'm confident each of us can take away valuable information from today's program back to our own unique clinical practice settings. We appreciate you sharing your expertise with us today. For those of you on the line, we hope you enjoyed today's webinar program. In the next 24 hours, you will receive an evaluation to complete to help us improve future programs. We'd also ask that if there's topics that are of interest to you, that you suggest those in the comment box, as we'll try to include those in future programs. Please take a few moments to complete this online survey to share your feedback, as it's very valuable. To learn more about future educational webinar programs, please visit pentaxmedical.com. This concludes today's program, so you may now disconnect. Thank you for joining, and have a wonderful day.